everyone, I'm Dr. Marina and today we're going to study UTIs, urinary tract infections. I will give you information regarding the classifications of UTIs, the causative agents, diagnosis, and finally, treatment. UTIs or urinary tract infections are those infections of either the bladder, urethra, ureters, or kidneys. They are most commonly caused by bacteria, especially by E. coli. The second leading cause of UTIs in sexually active female patients is Staphylococcus saprophyticus, and the third leading cause is Klebsiella pneumonia. Now, we can classify urinary tract infections by location into lower and upper UTIs. Infections of the bladder or urethra are called lower UTIs, namely they are either cystitis, urethritis, or prostatitis, and the clinical features regarding them include hematuria, increased urinary frequency, suprapubic tenderness, and dysuria. On the other hand, infections of kidneys or ureters are called upper UTIs. Namely, they can either be pyelonephritis, intrarenal or perinephric abscesses. The clinical presentation of these include fever, flank pain, fatigue, nausea, and vomiting. In addition to the basic information that I offered you in the previous slide, when referring to children patients, urinary incontinence, malodorous urine, irritability, poor feeding, and also failure to thrive are added to the clinical features. In male individuals, there can be prostatic or perineal pain, and in elders, delirium or acute confusion can be present. Now, we've prepared you a mnemonic to remember the causative agents that lead to UTIs. The bacteria that cause urinary tract infections are the following: Staphylococcus saprophyticus, E. coli, Enterococcus, Klebsiella, Proteus, and Pseudomonas. Now, let's take each and every infection specifically and talk about them in detail. Urethritis is mainly caused by Neisseria gonorrhea or chlamydia. It can manifest as dysuria, frequency, nocturia, and urethral discharge. When referring to the risk factors, these can include unprotected sexual activities, multiple sexual partners, and also unhygienic environment. The diagnosis is based on the positive microbiological cultures found in the urethral discharge. The treatment includes one of the following antibiotics: ceftriaxone, doxycycline, and azithromycin. If the urethritis is caused by Neisseria, ceftriaxone, a third generation of cephalosporins, should be chosen. And if it's chlamydia, doxy or azithro should be the considered drugs. Cystitis can have the following clinical manifestations: dysuria, frequency, nocturia, urgency, suprapubic pain, cloudy or foul smell urine, but remember, no fever. Risk factors should also be taken into account. The risk is higher in female patients, sexually active as well, obese, and diabetic ones, patients with vaginal infections too. The diagnosis is clinically based in comparison to the periclinical necessity in diagnosing urethritis. Referring specifically to the drug treatment of cystitis, antibiotics such as combination of trimethoprim sulfamethoxazole found under the name of Bactrim or nitrofurantoin, fosfomycin, or even Cipro are a safe choice. The treatment has to be adapted onto the type of infection because it can be an uncomplicated one or a complicated UTI. When talking about pyelonephritis, this can manifest as dysuria, frequency, nocturia, urgency, but flank pain and high spiking fever are the most specific ones to remember and trace. Risk factors regarding this type of infection include HIV-positive patients, iatrogenic immunosuppression, urogenital abnormalities. The diagnosis is based on urinalysis and also on urinary cultures. IV antimicrobial peptides and sulbactam or IV ceftriaxone can be used as a drug treatment in this case. If there is a complicated case with abscess and the pyelonephritis does not improve, a CT scan or an ultrasonography is needed. Drainage and antibiotics are needed in this situation. Moving forward, asymptomatic bacteriuria with no UTI symptoms can happen in elderly or hospitalized patients. The risk factors include cognitive impairment, diabetes, structural urinary tract abnormalities, and also indwelling catheters. The diagnosis is set via urinalysis and urinary cultures. Treatment in this case is not needed except in the following situations. Over 100,000 bacterial colonies found in the microbiological examination, pregnant women, or urologic procedures. If we are referring to a pregnant patient with this condition, amoxicillin should be considered as a first-line antibiotic and nitrofurantoin if penicillin resistant. Now, rehearsing the diagnosis matters in UTIs. In uncomplicated lower UTI in women, the urinalysis or microscopic examination is needed. If the periclinical examination turns out positive for pyuria or bacteriuria, we initiate a treatment. If it's negative, we need to check the urine culture results. If we have a case of a complicated lower UTI in a female patient, the diagnosis is also based on UA and UC results. Febrile UTI needs further investigations such as CT or ultrasonography. Urinalysis checks for pyuria, meaning white blood cells found in the urine, positive leukocyte esterase, bacteriuria, meaning bacteria present in the urine, and leukocyte casts, concludant for pyelonephritis. Urine cultures are positive if there is significant bacteriuria. And here we are referring to the cases of complicated UTI, pyelonephritis, and uncomplicated UTI, recurrent UTI in elders over 65 years old, equivocal urinalysis and typical symptoms, and the case with multi-resistant pathogens. To conclude, UTIs in patients are frequent conditions that you're going to encounter in your day-to-day life as a doctor or a med school student. I want you to remember that treatment differs from patient to patient, and the differential diagnosis is a very important aspect we need to understand in better diagnosing and treating these infections. Thank you for watching, and don't forget to subscribe and like our video.